Okay, let's return to your specialty. All of us who can use our eyes all the time, except when we're asleep. And it makes it very clear that this is a critical area for our well-being. People want to know what symptoms they may develop that would lead them to ask for your help. Now, some things maybe are asymptomatic until you find them, but people might want to know, gee, if I feel a pain here or a blurring there or whatever.
Sure. I mean, the typical, my eyes are itchy, from the eyes are itchy to asymptomatic vision loss that can be happening without you knowing it. And that's really the big concern with a lot of what we take care of. Glaucoma, which is a disease of the optic nerve. The optic nerve, I like to explain to people, it's like the power cord. If you have an appliance and you plug it into the wall, the cord is what plugs into the wall where the electricity goes through that and turns on that appliance. The optic nerve is basically what turns on your eye. And so that's the power cord of your eye. And that is damaged over time when you have glaucoma. You develop what we call an optic neuropathy. So the nerve is damaged slowly, typically slowly over time. And it's asymptomatic. You wouldn't really know you had glaucoma until you had a very advanced case of that. And that's why half the people in this country who have glaucoma are walking around undiagnosed. It's asymptomatic. The only way you'd really know if your eye pressure was up was if it was an emergent level where typical pressure would be 8 to 21. You could have a pressure of 35 or 40 and not feel it at all. In fact, you could have a pressure probably up to 50. When you start getting above a certain level, patients can start feeling an achiness or a pain, maybe associated knowing something's wrong, but a lot of people will just kind of think, maybe there's something there, maybe not. So glaucoma typically is without symptoms until the very late stages when you have loss of peripheral vision. But there are other things that we diagnose routinely. We diagnose diabetics. Patients will come in with symptoms of diabetes or signs of diabetes in their eye and have no idea that they've had diabetes for 5 or 6 years. We send them off to their primary care doctor, seeing typical signs in the eye, and that can be little blood vessels that are broken or dilated. And we know diabetes is the number one cause of vision loss in those who are in working age in America. And it's basically it's almost everywhere now, and there's a lot of diabetics, and it's very important for diabetics to receive yearly eye exams. Just your average run-of-the-mill vision loss. A lot of people don't realize they have blurred vision because they don't really know what it's like to have clear vision. So I know when I was younger, I was nearsighted. I didn't realize I was nearsighted until I was out playing golf with my dad, and I couldn't see the golf ball. And he said, "What do you mean you can't see that?" And so I went to the doctor, and sure enough, I was nearsighted. And the first time I put on glasses, I couldn't believe it. And I hear this all the time. I didn't know there were leaves on trees. So unless you're testing that, you may be walking around with blurred vision and have no idea that you have blurred vision.
That's a good recommendation for the viewers, that they shouldn't put it off. By the by, your discussion of glaucoma takes over a question I was going to ask later. Anyway, people more often than not, when they have vision issues or not seeing clearly, they'll go to an optometrist and get fitted for glasses. Did the optometrists report to tell them to go see an ophthalmologist because they may have a problem, or are they not able to look at that?
Well, actually, optometrists do the full range of eye care short of surgical procedures, and so a lot of optometrists will provide medical eye care, and that can include taking care of glaucoma patients, monitoring diabetic patients. Typically, if a patient has a cataract or requires some kind of a surgical intervention, then they may have ophthalmologists that they're going to be working closely with, and they would refer those patients. But and it depends on the level of optometrist. Some optometrists want to do mostly glasses and contact lenses, and if they have a medical diagnosis, they're going to automatically refer that to an ophthalmologist. There are a lot of optometrists who take care of the medical diagnoses, and they'll manage glaucoma patients. And if they feel that there's something that is needed on a surgical intervention wise, whether they need a laser or surgery, then they would then refer that patient downstream. So a lot of that is very different, and it depends on the level of optometrist in terms of how they want their practice to run.
Okay, that's also very important, because I was not aware of that. I thought of optometrists as principally people who found out what your vision problem was and prescribed some sort of corrective lens, glasses or what. I know as part of an annual checkup, there's a pretty thorough test of one's ability to see, leading to a prescription for corrective eyewear if needed. And there are all these other diseases of the eye that I think I'd like to hear you speak about. You've discussed glaucoma, which takes away another question. But there are others like macular degeneration, retinal detachment, cataracts, and so on, that occur at various ages as well.
Sure.
So can you describe the sorts of things that would lead a person to seek out your help?
Well, first of all, everybody over the age of 40 should at least have a routine eye exam at that age, and hopefully they've had one before then. If they've got a family history of glaucoma or macular degeneration or diabetes, any of those things, that would prompt them to have an exam at an earlier stage. So the 4 leading causes of blindness in the United States are glaucoma, macular degeneration, cataract, and diabetic retinopathy. All of those are picked up on pretty much on a routine eye exam. So when you come into our office for an exam, we're going to check your vision. We're going to check your what we call a refraction, which is your ability to see the best that you can see. Would glasses improve your visual acuity? And then we determine, and obviously everybody at a certain point is going to require, if they have good distance vision, typically in your 40s, you're going to start losing your near vision and require some magnification. Condition called presbyopia. That's the aging of the lens where it no longer focuses. So all of us,
it doesn't focus up close?
It won't focus up close.
Okay.
Well, if you have good distance vision. Now, if you're nearsighted, you can actually see up close, but you can't see the distance. But if we fully correct your distance, then it unmasks the fact that your lens can no longer focus up close. So what we call presbyopia affects all of us, and it affects different people at different times based on their underlying refractive error. So if you're nearsighted, you can take off your glasses and read up until any age, but you then won't be able to see the distance. So if you correct your distance vision, then you'll no longer be able to see up close if you're over that age. Typically around 40 is when people may start noticing it. As far as macular degeneration, that's not something we see in everyone, but certainly family history is a risk for that. If you're a smoker, much more at risk. If you do have the signs of macular or a family history of that, you're very likely to lose your vision if you're a smoker. So UV exposure is very important to limit. So sunglasses is very important. I'm constantly on my kids about wearing sunglasses every time they go outside, starting at an early age. Protects the eyes, the tissue around your eyes, slows the progression of cataract, and protects you with the macula. So macular degeneration, very common. If we pick it up early.
Would you explain to the viewers macular degeneration?
So the macula refers to the center part of your retina. And if your eye were a camera, the retina would be the film in the camera. So the retina is in the back of the eye, and the retina is basically where the image is transmitted onto the film, and then it's taken down the optic nerve to the brain and interpreted as an image. So the macula refers to just the center portion of your retina, the most important part if you're looking at details. So if you're looking at my face and you're looking at fine detail, the macula would be that center portion. So when you develop macular degeneration, there's typically a distortion or a loss of the center part of the retina. And that's the deterioration happens in the center. Patients always ask, am I going to go blind completely? Well, you may be legally blind, which means you may not see the big E on the eye chart, but all of your peripheral vision should still be intact. So even the end stage of macular degeneration does not mean the lights go out and it's black. That's different for glaucoma. If you end it with end stage glaucoma, you lose all of your vision and it's like the lights are turned out. And a combination of macular degeneration and glaucoma the macular can take the center part and the peripheral can start to shrink from glaucoma. So those conditions sometimes occur together. But macular degeneration, there's been tremendous advances with macular degeneration over the last 10 to 15 years, where, and there's 2 different types. There's a dry form, which is, the dry form is the most common. It's just like the ground, the retina just starts to deteriorate and break apart and almost turn to sand and just disintegrate. And when that happens, you end up with what we call a scotoma, which is, it's like someone cut out the center part of a picture. So if you look directly at something, you try to read or you try to look at a road sign or television, you wouldn't see the detail of it in the center. It would be blacked out or gray, but you'd see the peripheral. And then there's the wet form, which is a more severe form. I think about 12% of macular degeneration patients will convert to wet degeneration. In the past, we had no treatment for it. And the wet refers to leaky blood vessels. So either blood or fluid will start to leak and create the swelling in the center portion of the retina. Ultimately, that blood or fluid will lead to deterioration, and the retina will start to become permanently damaged. And so getting that fluid out of the retina in the past was very difficult to do. They were doing different treatments. Back in the past, they used to use lasers where they would just burn that spot, but then you ended up with a permanent loss of that retina. And so people would say, well, it's better to have, you'd have the laser and it wouldn't get bigger, but you'd have a permanent spot in the center. Thankfully, they came up with injections which actually are able to dry up the blood vessels, and it's been a miracle. So we could treat wet macular degeneration. I've had patients who have had wet macular for a decade and still preserved their central vision. So while it's worse form than dry, there's actually a treatment for it. There's also been some studies that have shown some benefit from taking vitamins. Right now, the recommendation is for the AREDS2, AREDS2. It was a study, a 10-year study looking at patients who took macular degeneration vitamins versus those who didn't. And they looked at a group of patients that had moderate macular to begin with. So it wasn't extrapolated to everyone, but we typically say if you have risks of macular degeneration, it's worthwhile to take the vitamins. But they showed over 10 years that those who took the vitamins did better than those who didn't. And so we recommend vitamins. Typically, my patients who come in with macular degeneration, I'll tell them 3 things that you can do. Wear sunglasses, don't smoke, and take the vitamins. And follow up, obviously, for routine care.